everybody. My name's Jonny Wilkinson, and thanks to the IFAD team for the invite to talk to you all about point of care ultrasound in COVID. Now, ultrasound particularly hit the limelight during COVID from the lung point of view, certainly, but also, I think, in general, and people started to pay far more attention to its utility. So, let's take the community. Obviously, patients out there have been coughing and sneezing and spreading. And this is the modality whereby the virus gets from person to person, as we all know. And the advent and usage of face masks has hopefully minimised that. And we all know that it protects other people from us rather than us from other people. Nonetheless, the virus has managed to propagate itself around via wave 1, which we all witnessed from March, April, May time. And now we're in wave 2. So the virus gets into the small and distal airways and affects the alveolar cells, utilising their own internal mechanisms for reproduction, and it basically parasitises our cells to make copies of itself and damages the cells accordingly, and in doing so causes problems with the alveolar membrane and gas exchange. Presentation of COVID was fairly simple initially, thought to be cough, shortness of breath, fever, and headache, so flu-like symptoms. Quite a lot of nausea and vomiting associated, sometimes nothing at all, sometimes just loss of smell and loss of taste. And indeed, loss of smell and loss of taste have almost become pathognomonic for the disease process, whereby it has its effects centrally. So coming in through the front door, what are we seeing and what did we see with our patients? And then we're going to get on to the ultrasound side of things. So patients came in a traffic light system or a spectrum of disease severity. So you had those that walked in, pretty fine, able to talk, and sat to a 94% or more. Not so much of a worry, and many of these patients we were sending home with home monitoring bands on, with various parameters to observe whereby they would have to come back in if they got worse. Next batch were the sort of amber category who didn't look very well, and the SATs were below 94%. Now, these guys we couldn't send home, so we tended to keep them in. Then you had patients who came in extremely clapped out, very, very sick, with SATs below 88%. So the virus had really taken hold in some of these patients, and they were the red category. So ambers and reds stayed in. Now, the utilisation of the stethoscope, I'm always an advocate that I don't use it very often. It is difficult in the noisy ICU environment, and frankly now with the advent of portable devices, handheld devices, and extremely readily available ultrasound, I rarely use mine. Because for me, point of care ultrasound is looking into the patient's body using sound waves. And of course, with the portable handheld ultrasound, we are now looking at the engine and not just what comes out of the exhaust pipe. The advantages of point of care ultrasound in COVID particularly, it's sensitive, it's fast to perform at the bedside. You can keep an eye on the disease process, there are no transfers anywhere else, no irradiation, and it's repeatable. So there's no need to take people and infect other resources or other areas of the hospital like the CT scanner, and you don't need a portable chest x-ray. So lots of algorithms were put forward, and this is ours from Northampton. It takes you from admission right through to what you need to do with your oxygen, right through to where you escalate, and do you escalate in fact. An ultrasound can come in at admission at the O2 decision point and can give you your help whether you need to escalate or not. So what do we look for? Well, we put the probe on the anterior points, areas 1 and 2, and then we move down to the lung bases at the PLAPS points in 3 and in 4. You can even scan from the back in a proned patient at areas 5 and 6 and get good views of the lung. And you can see here that those points will catch most of the lobar areas of the lung and indeed will give us decent coverage, similar to what we would get with any stethoscope. You can put them on the same places. We're looking for interstitial fluid, and this is the main problem and the main thing we're seeing sonographically with COVID. It's a pneumonitis when it gets severe and it damages the alveolar membranes. So what do we see? Well, here's a normal lung, and we see the A-line pattern, which is just reflections of the pleural slide going down through the chest. This is normal, and this is air interfering with sound wave passage. So the patients you see this sort of thing on, probably the ones who've walked in with SATs above 94. Then we start to see thickening of the pleura, and we see still lung sliding, but it might be reduced, but there is definite B-line profiling coming on at this stage. Now, this is interstitial fluid developing from the pneumonitis, and again interference with the sound waves, and indeed allowing them to pass through the chest due to fluid. So the patients could be well, they could be the guys who come in with SATs below 94 looking a bit clapped out. So it's a spectrum, but this is where it starts to get abnormal. By the time we're seeing severe B-line profiling, so much they're coalescing and almost whiting out the lung field, these patients are likely to have SATs of less than 94, and indeed they might have SATs of less than 88. So we're starting to see thickened irregular pleura that became very popular in COVID ultrasound as one of the diagnostic entities, and certainly more B-line profiling visible as we see. By the time we're seeing consolidation, a really bad infection down at the bases and sometimes subpleurally further up on the anterior points of the chest, we're seeing irregular pleura, we're seeing B-line profiling, we're seeing shred signing where normal tissue meets abnormal tissue, and consolidation, which looks almost like liver tissue or hepatization. These guys are sick. And even worse, severe consolidation. You can see static and dynamic air bronchogram profiling going on here, and certainly hepatized lung, So lung that looks like liver because it has the same echogenicity as liver tissue because it becomes filled with fluid and becomes very heavy. These patients are not well. It was proposed there was a type L and a type H phenotype, and these patients behave slightly differently, and indeed these CT scans demonstrate this consolidatory process is more severe in type H than L. The compliance is much better in type L than it is in type H, and there are different things to do. So let's talk about those, and let's talk about the implications of scanning on these people. The L phenotype, they've got a low elastance but a high lung compliance. Therefore, the amount of non-aerated tissue is actually quite low, so recruitability is quite low. So sometimes you can make these patients worse by adding a lot of PEEP in and going overzealously on the ventilator. They have low VQ ratios, and because of that, hypoxia is actually probably due to perfusion problems rather than an actual direct hypoxia and membrane destruction, and it's due to loss of hypoxic vasoconstriction. The lung doesn't weigh much because there's not much fluid in, and you see subpleural ground glass opacities on the CT and only moderate increases in lung weight. And it's low recruitability, as I mentioned, and therefore that's why PEEP can have a detrimental effect. By the time they're at type H, there's a high elastance and low compliance. This is where PEEP can come in, and this is where PEEP can help, opening the lungs up and increasing FiO2 as you do so. There's a high right to left shunt, understandably, and this is due to the fraction of cardiac output that's perfusing areas that really aren't perfusable. There's a high lung weight, and this is why you get remarkable increases in lung weight that are actually visible on CT scan with areas of lots of posterior whiteness. And the high recruitability is applicable to PEEP and indeed to proning. And proning has helped lots of these patients, and we do this for 16 hours at a time, flip them back, and we see quite marked improvements. Sometimes patients don't respond, but in the main, proning works. And indeed, in the patients who haven't been intubated yet, self-proning is a remarkable thing, and it does make a huge difference. So let's look at Daniel Lichtenstein's Blue protocol, slightly adapted for COVID. So if you've got your hypoxic patient and they have been positive for COVID-19, we can make a Blue protocolized assessment. And if we follow down, we get B lines appearing with the pneumonitis process and the thickening of the pleura. These patients sometimes respond to diuretics, keep them dry, don't overdo the IV fluid certainly, and put PEEP on board if they're indeed the type L versus type H. The next thing we can visualize as it gets worse, more B-line profiling, thickened pleura, subpleural consolidation, and indeed basal consolidation as mentioned. These are more likely the type H's that can respond to proning. Now, heart-lung interaction is going to come in here, of course, because not all B-lines and fluid in the lung is to do with COVID or indeed a process going on in the lung, it's the heart as well, and these guys do get affected as a multi-system disease. So septic cardiomyopathy is something we've certainly seen in COVID. You get myocarditis and heart failure. So these patients respond to diuretics again and some maybe dobutamine to drive the LV a bit better. Then we start to see other things going wrong. So we all know that this is a process that can cause severe vasculitis, and indeed it's a thrombotic process with microvascular thrombi. Look for a DVT. If you see a DVT, please scan the heart, because due to hypoxic pulmonary vasoconstriction, severe hypoxia, they get RV failure, and in this case, obviously McConnell's sign, dilated right side, and failure due to a PE. So please be careful to exclude PE. Lots go for a VQ scan or an HRCT, and indeed some go for CTPA. But a dose of heparin, more so than you would give normally, maybe treatment dose in fact for a PE, and you might need some noradrenaline to support the left side as the right side impinges on it. So these are things to consider, and you can pick all of this up on ultrasound quite readily. So you can see that heart-lung interaction is very important, so let's not forget the heart and obsess with the lungs. Here's some clinical examples, and you can see in this situation here we have a heart which does not have a good LV ejection fraction as the first. And we have B-line profiling separated by A-line profiling, which is quite common in the early stages. So you'll see preservation of A-line profiling, but lots of fluid and thickened pleura. And also in this one, you can see lots of B-lines on the other side of the chest, which are more coalescent. So the disease severity may be worse on the other side. And if you look carefully here, there is subpleural consolidation to see, sort of ditting into that pleural line, and the irregular pleural line can be well visualized there. This is the example I was talking about with the myocarditis and the reduced ejection fraction due to COVID. It's a multi-system disease, and you can see reduced ejection fraction. And fluid in this circumstance with subpleural consolidation of B-lines may indeed be heart as well as lung. Here's the pneumonitis, and indeed the LV fraction is dropped, so therefore the fluid could be a mix. And there's the base with the spine sign above the diaphragm, and you can see a really hepatized echolucent lung. Another example, rapid respiratory rate, B-line profiling left to right with a thickened pleura. And here we have a very plethoric IVC that isn't collapsing much. It's 2.3 centimetres, demonstrating right-sided overload and indeed possibly venous congestion as a result of fluid overload. A base that's echogenic, collapsed, and has paraneumonic effusion around it as well. Interestingly, Yale Tung Chen diarised his COVID journey, and you can see from the left here on day one he was normal when he started to become ill. Then the test became positive, and over time he developed thickened pleura and B-line profiling, which got worse. It was flicked in with some subpleural consolidation by day 11-12, and interestingly, just prior to that he lost his smell. Going on through as he started to get better, it is still notable that he had some fibrotic lack of sliding in the lung on the pleura, and he also had remaining B-line profiling, and we are seeing remaining B-line, solitary B-line profiling in patients even when they are test negative and are getting better and feel physically better. This may be why many patients still feel physically unwell even weeks after they've had the disease, and some months. So it was very nice of him and gallant of him to do this diary, and I've just put it together for us in one infographic. So thank you to him, and I'm glad he got better. So lung ultrasound is extremely useful, and indeed heart-lung ultrasound is extremely useful in the COVID disease because it takes the guesswork out of it, in my opinion. We can shine a torch inside the patient's body and see the direct impact the disease is having sonographically on a patient. And it is also extremely useful in order to provide diuretic therapy, antithrombotic therapy, and indeed to help out LVs that are suffering due to RV failure and hypoxic vasoconstriction. There are other ways to monitor the disease, but without ultrasound, I don't think I could look after my COVID patients as well. So it is definitely well worth adding into the 4 pillars of examination: inspection, palpation, percussion, auscultation, and obviously the 5th now of insonation. So please learn to use lung ultrasound, perhaps learn some heart-lung ultrasound, and you can help your patients and beat this virus. Thank you very much.